Yes.
Okay, great. So as Dr. Hijazi said, I will be talking in our first session today about the principles of health economics for non-health economists. So I have 4 key objectives. First, to understand the basic principles of health economics in general, exploring the different types of economic evaluations in healthcare, and trying to discuss the link between randomized clinical trials and health economic evaluation, discussing some of the potential implications of health economics in brief. We have questions for the audience. If you can show the question, Dr. Hijazi.
Yes, I will share the first question.
Okay, so this is our first question. We're trying to engage the participants. We would like to know the knowledge that you have about the field today. So what are the evidence requirements for new interventions to be approved? Is it safety, efficacy, quality, ease of use, or other? I hope if we give the audience the chance to pick more than one option. However, let's see if...
Yeah, what was put in the poll, it's only single choice. So we'll see the opinions. Okay. So far, we have almost half of the attendees already voted. Mm-hmm. So please vote or choose your answer. Okay, we can have like, let me say, 5 seconds more, guys. So please vote. Okay, we can end it now, Dr. Anna.
Mm-hmm. So can we see the results?
Yeah. Yes, sure.
Okay, so most people think that the most important requirement is safety, followed by efficacy and quality.
Yeah.
Excellent.
So I think 50%. We cannot,
yeah, definitely.
Almost 50% of safety.
Definitely. I think we cannot disagree with this, honestly. And my understanding is most of our participants are pharmacists, so this is quite expected. So let's see if this is right or no. Okay, so I'll just would like to start my presentation with this slide. As I said, I'm here to convince you all that health economics is important. So I would like to shock you in the beginning with these numbers. This is our global healthcare spending. So it's a worldwide expenditure of healthcare in the whole world, which exceeded 8.3 trillion in 2018. And this is really big number. And this makes around 10% of global GDP. So you can imagine that we are spending 10% of our economic revenues or GDPs in healthcare. The map on the right shows the healthcare spending across countries. And as you can see, our region is having significant spending on healthcare compared to other regions in the world. So what drives these eye-popping numbers? Why we are spending a lot on healthcare? First, because of the population aging. We have also increasing demand. We have also the clinical and technology advances around the world. We know now that we have a lot of technology advances. We have new procedures, new interventions, including pharmaceuticals and medical devices, which prolong the life of the population and also increase the demand. We have other economic costs, other economic reasons or factors, such as the rising labor costs and the economic recovery and the improvement in a coverage plan for healthcare. So this shows a very simple problem and very difficult to solve, of course, which is the economics dilemma. Increasing. Can you please, somebody is talking, if you can mute, please. So as I said, increasing resources are scarce, however, human wants are unlimited. And 30 years ago, we used to have very limited treatment options for the patients. And nowadays, luckily, we have with the technology advances, a lot of treatment options. For some of the disease areas, we have at least 5 or 6 treatment lines. However, this growth is not witnessed with the healthcare resources. Our budgets are limited and we cannot meet all the healthcare needs. This slide shows the major healthcare dimensions: access to care, quality of the services, and costs. And the important question here, or I would like to call it the impossible question, is whether we can improve access to care or improve quality to care without increasing the resources or with the same amount of money spent. Scientists or economists in particular spent the last 2 decades working on this, trying to find a tool that can help them in improving the services in healthcare in particular without inflation in budgets, which I call it making the impossible possible, honestly. However, the recipe or the ingredient to make the impossible possible is the health economics. Health economics is defined as the comparative analysis of alternative courses of action in terms of both their costs and consequences. So basically, we are comparing 2 or more options, standard of care and usually novel treatment, in terms of both costs and benefits, and to try to identify the value of a new innovation compared to standard of care. So this can help us in achieving more effective, efficient, and equitable healthcare systems, and it can help us in assessing the value of new treatment options. So as you all know, and as you answered, most or all regulators, all regulatory bodies are approving the drugs based on safety, efficacy, and quality. However, nowadays, in a world of increasing global healthcare spending, evidence of quality, efficacy, and safety is no longer enough. And a new drug to ensure reimbursement of new drugs by the healthcare payers, these new drugs must also show evidence of cost effectiveness, which means that these drugs must show that they are offering, I would say, superior value in terms of benefit or health gain compared to standard of care. And that's what industry call the 4th hurdle, or the 4th challenge that they have to overcome to be reimbursed. So this is my first take-home message from this presentation. This is very important, and in my opinion, every pharmacist should be aware of this fact. Quality, safety, efficacy is not enough nowadays. The new drug must also be cost effective. So what are the types of economic evaluations? First of all, I would like just to quickly show you some of the uses or applications of health economics, which will be discussed in details in our next session. First of all, priority setting. It's a tool that can allow you in ranking. If you have a list of interventions that you want to adapt, this tool can help you in ranking these items on the list based on the value that they provide to the patients. It can help you in proposing for approval for new projects, in budget management, and also in improving the overall efficiency of the system. Type of studies, we have economic evaluation, disease burden, and budget impact. And I will start with economic evaluation, and I will spend good time on it because economic evaluation is the most relevant to pharmacists in particular during the B&T decision making. So to assess the value of new products, usually economists use one of these four types of economic evaluation. So we have cost minimization analysis, cost benefit analysis, cost effectiveness analysis, and cost utility analysis. The last two are the most commonly used ones, and we will talk about all of them in details. So starting with cost minimization analysis, this is the simplest method. Usually it compares, used for comparing or assessing alternatives that have proven equivalency in benefit. So if you have two products that you think are clinically equivalent in terms of clinical benefit, however, the cost between these two is different. For example, if you want to compare generics or generic to brand, or original biologic versus biosimilars, where you know that using totality of evidence trials is approved to be with similar benefit to the biosimilar, however, the cost is totally different. The second type is cost-benefit analysis. In cost-benefit analysis, economists are trying to convert or measure the clinical benefit in monetary values. So they try to compute the economic value in dollars or in reals, in dirhams of the clinical benefit. And if the benefits are more than the cost, then we can implement the technology. If not, then it should be rejected. However, this is very difficult. You can imagine how can we measure, for example, pain or suffering or dysfunction in monetary value, which means that this kind of analysis is rarely used. Moving to the famous cost effectiveness analysis, the most commonly used or known economic evaluation. And cost effectiveness analysis is the study design in which the consequences of different interventions are measured using a natural unit. So perhaps, for example, you have two treatment options for the same disease area, and you want to measure the cost per a natural unit. For example, per life years gained, the cost per number of heart attacks, or the cost per case detected. So here the alternative interventions are then compared by cost per unit of effectiveness. And if you can see here that we are comparing alternatives from the same disease area, which limit the use of cost effectiveness analysis. So let's take a very simple example just to familiarize you with the idea in general. So imagine that we are comparing two interventions, A, which is a novel treatment, and B, which is the standard of care for the same condition. So let's assume that B is less expensive, but more effective than A. So which one do you think will be chosen? Definitely B, because it's cheaper and more effective. I believe I just said that maybe B is the novel treatment, A is standard of care. I apologize. So we will take the novel treatment because it's less expensive and more effective. Let's take another scenario. What if the novel treatment or the new treatment option is more expensive? However, it is less effective than A. So what treatment option might we will adapt? Definitely the old one, because we will not go to more expensive item and it is also inferior. So the answer is very obvious here. Going to another option or another scenario, which is more realistic, where the novel treatment is more expensive, but also more effective compared to standard of care. Or a fourth scenario, when the new treatment is cheaper, but also slightly less effective. And this is not also quite common. However, it is, I remember seeing this scenario in BNT. Again, it's very difficult to assess. So what we do here in this case, using a cost effectiveness analysis, is that we are calculating the incremental cost effectiveness ratio, which is the difference in cost between the two, the new minus the standard of care, divided by the difference in effectiveness, which is the effectiveness in the new treatment minus effectiveness in the comparator. So taking an example here, let's say that option A has a cure rate of 90%. Option B have a cure rate of 95%. So the incremental difference in efficacy is only 5%. However, the cost per treatment course in treatment A is 100 Saudi Riyal, while the cost of the course for treatment B is 1,000 Saudi Riyal. So you can see here the difference is 900 Saudi Riyal. So if you calculate the ICER, or the cost per additional case cured, it will say that the ICER is 18,000 Saudi Riyal. So if you look at the numbers, you say only I have 5% improvement for 10 times the cost. So maybe you will say no. And if you just...
Dr. Hannah,
yes, doctor?
we can't hear you.
Can you hear me now?
Yes, I can hear you now. We lost you for a few seconds.
Okay, I'll change my... is it better now?
Yes, from my side, yes.
Okay.
I hope that everyone is okay.
Okay. So I was just saying that perhaps if you look at this example, you will say that a 5% improvement difference between the two options for 10 times the cost might look not cost effective in the beginning. But if you calculate the ICER, you will find that the ICER is 18,000 Saudi Riyal, which means that for every additional case you cure, it will cost you 18,000 Riyal. So even this number by itself, it doesn't tell you whether to adapt the option or not. It depends on several things. For example, it depends on whether you think treatment B is worthwhile, this 18,000 Saudi Riyal. Can you afford 18,000 Saudi Riyal for every case? The number of cases you have, would you prefer to spend this amount of money on something else? So it depends on several factors, including also the perspective, whether you are payer, your physician, or maybe you are from the government and you will want to know the social cost of the disease. So what impact the ICER? First of all, drug price, not only drug. What I wanted to say is the technology or the intervention price, the impact on survival, the impact on quality of life as well, the administration costs, the related sources or resources that might accompany the treatment, physician time, pharmacist time, nurse time, the management of complications and side effects, and several other issues can impact the ICER. But what is the cutoff point that tells you that this ICER is cost effective or not? It depends on the threshold, which we will be talking about in a while. So these are the kind of things that we calculate. The cost of pharmaceuticals, the cost of staff, a new infrastructure if needed. For example, if it is a smoking drug, you will need a smoking clinic, smoking cessation clinic, or obesity clinic, for example. If it requires training, or there is side effects and complications, cost of monitoring, and also cost of non-responders, because if, for example, you say that 30% of the patients will not respond based on the RCT, then you have to calculate the cost of non-responders. For possible effectiveness, we have the number of successful treatments or number of life years gained, or any outcome such as quality of life or cases cured or attacks avoided. Moving now to the last type of economic evaluation, which is the cost utility analysis, and this is the gold standard by most payers or most health technology assessment agencies. And by the way, most of the cost effectiveness studies that you see or you read in the literature are actually cost utility analysis, but people, I don't know why they call it cost effectiveness. So the outcome expressed here in cost utility analysis is QALY. So QALY, the good thing about QALY that it captures both survival and quality of life. So here QALY is measured between 0 and 1, where 0 is death and 1 is perfect health. And how can we measure the QALY? We capture these from patient-reported surveys. The most famous ones are EQ5D and SF6D. What makes cost utility is the gold standard is the fact that it can be applied across disease areas. So it's unlike the cost effectiveness, it does not measure a natural unit, for example, a percentage drop in cholesterol or blood pressure, which means that QALY can be used to any disease area. So as I said, willingness to pay threshold is the cutoff point that tells you whether your ICER is cost effective or not, because what is cost effective in Saudi might not be cost effective in UAE or in Egypt or any other country in the world. Some countries have a official announced thresholds, and some countries don't. For example, in the US, the threshold is between 50 and 100,000 US dollar per QALY. So if your study shows that the healthcare intervention you're studying is yielding an ICER of, say, 50,000 US dollar, then it might be considered cost effective. In the UK, they have two different thresholds. One for most therapies, which is, I think the number here is wrong. I apologize for this. It's 20,000 pound for most therapy and 50,000 pound for oncology. They also use the one for oncology for end-of-life treatments. So what about our region? We are using the recommended threshold by WHO, which is 1 to 3 times the GDP per capita. So if the drug is the cost per QALY or the ICER is below 1 GDP per capita, then it's considered very cost effective. Anything between 1 and 3 is cost effective. Anything above 3 GDPs is considered not cost effective. For example, if we take the case of Saudi Arabia, our GDP was in 2020 $20,000 US. So anything below 3 times this number will be considered cost effective. So this is the take-home message for this section of the presentation. We have 4 types of analysis. The most widely used is cost-utility analysis, and the choice of the tool depends on the context or the perspective, the disease nature, and outcome nature. So perhaps if you have 2 treatment options and you can spend your budget within this disease area, you might use cost-effectiveness analysis. Say you have 2 treatments for lowering the cholesterol, then you can use cost-effectiveness. But if you are comparing something for hypertension with something for diabetes, you might go for cost-utility. Just a few information about health technology assessments agencies around the world. Currently, mostly in Europe, for example, every single country has some sort of agency or institute. They conduct pharmacoeconomics, they provide recommendation for reimbursement. For example, NICE in the UK, CADITH in Canada, and the SMC in Scotland. So we have here also other type of economic evaluation, which is the disease burden. Disease burden studies or cost of illness are studies that are conducted to calculate the overall burden of a disease. Usually these kind of studies are done at national level or regional level sometimes. So they use data from incidence, prevalence, mortality, and morbidity, sometimes quality of life data, and they calculate the cost of illness, whether it is direct medical or non-medical costs, such as the costs of treating the disease from payer perspective, non-medical, such as the expenses that are directly linked to the disease, such as the cost of travel or transportation or special diet, for example, but they are not considered medical. We have also indirect costs, such as the social cost, for example, cost of daycare or care provider, and also the lost productivity by the patient or the care provider. This is an example. For example, if we calculate the clinical burden, for example, the total cases we have in certain geographical area, or for example, the length of a stay for this disease, and then we multiply it by the cost and the resource use, which will give us the total cost. I will not go through the example in details for sake of time. We have also budget impact analysis, and this is very important. It's where you calculate all the costs associated with the product or the intervention, but you are not calculating the clinical value. And this doesn't mean that you are calculating only the direct acquisition cost. No, you are calculating the costs, for example, the probability of having certain complication or side effect, and then you calculate the cost of this event. You do this for 2 scenarios, and then you calculate the overall costs. And this is very important because it addresses a very important question for payers, which is affordability. So now we will be talking about, and this will be the last section of this presentation, and it will be about modeling, which is the technical tool of health economic evaluation. I believe we have the second question here, Dr. Hijazi. We have here this slide that shows the difference between clinical trials and health economic evaluations. And I believe this is very, very obvious. If we can have the question, please.
Yes, I started the question.
Okay, so if we consider the differences between RCTs and health economic studies, which we will be talking about in a bit, but I know that most of you are at least familiar with the characteristics of RCTs. In your opinion, why do you think we need to do economic modeling in addition to RCT?
Dr. Hana, your voice is interrupted.
Still?
So I may interfere. I will just read the question to
please.
the doctors again. So considering the difference between randomized controlled trials and health economic studies, why do you think economic modeling is conducted? And please choose one choice. I don't see any participation, so we need to check if it is already.
Yeah, I can see it.
You can see it, okay. So this is for the audience. Would you please answer the question? I believe there is something in the question. So I received a comment that they can't submit, and I see it's only 0 answered. So I believe there's something could be in the question.
Can we pause it again?
Yeah, I will try to make it again.
Please.
Okay. Okay, now people can participate. I see participation, yes. Okay. Yeah. It's going well. Few more seconds. We need the highest possible number of answers. I see the answer number now is better than the first question.
I think last time you didn't open for attendees.
Yeah, probably.
Yeah, I think that's why, because they said the system is not responding.
Yeah, but now I see. Yeah.
Well, it's good news because I thought nobody is listening. So.
Yeah, I was confused too. Okay, 5 more seconds. If anyone else would like to vote or answer. Okay, I believe we can end it now. And I will share the results. And you can see, Dr. Hana, the last one is 75%.
Great, yeah. I believe I don't need to complete my slides. They all got the answer. Well, yes,
this means that you did a great job.
Hopefully, yeah. So yes, we're conducting economic modeling because we need to complement the limitations that RCT have. Although these limitations are intended in the environment of RCT. So this is a comparison of RCT and health economic evaluation. In RCT, we measure efficacy, while in health economic evaluation, we measure cost effectiveness. In the population in RCT is identical population that are selected carefully. However, in health economic evaluation, I don't know where is the answer, but it's a hypothetical cohort of patients that represent the real world population. In RCT, we intend to treat the patients, while in economic evaluation, we simulate or model as treated in the real world. The time horizon in RCT is short-term, while it should be long-term in health economic evaluations. It should be long enough to capture all the future costs and consequences. Most of the times we take lifetime time horizon, or sometimes 30 years. The purpose for RCTs is authorization, definitely, from regulatory bodies, while for health economic evaluations is for reimbursement decisions. The setting in clinical trial is multi-country trials.
I can't hear you anymore.
Again?
So I lost your voice for like 5-7 seconds.
Can you hear me now?
Yes, I can. Okay, please go ahead.
Great. So the purpose I was saying for a clinical trial is to get authorization by regulatory bodies, while the purpose is reimbursement in health economic evaluation. The setting in clinical trial is multi-country trials, while in health economic evaluation, you do it for this country specifically. And if you do it for another country, then you have to localize the model. In RCT, we have very strict protocol instructions, while in economic evaluations, we do what we do normally, even if it is not perfect. We use a protocol-induced resource use in RCT, while in health economic evaluation, we use real-world resources use. So as you can see, health economic evaluations is not intended to replace RCTs, but to complement it and to calculate the possible consequences in terms of costs and benefits. So we use all these data from RCT, epidemiological data, costing data, and quality of life data to feed the health economic model, which leads to reducing the uncertainty and helping in providing informed decision. So what is modeling? I apologize. So modeling is a mathematical tools, a mathematical modeling to estimate the future total impact of the product over time on the health or clinical benefits from either payer, individual, or societal perspective. And this is very important because you need to know what would be the impact of your decision on the future. So it uses, as I said, efficacy data from RCTs, epidemiological data, and the quality of life data, in addition to disease management data, for example, the disease history, based on expert opinion or sometimes patient advocacy groups, to model the patient journey of a hypothetical group of patients. So we have range of modeling techniques. For example, this is a decision tree. Decision tree here, it models all the possible treatment paths and outcomes. Each alternative is shown here as a branch, and each branch is connected to by a decision node, which represents a choice, either to go with treatment A or B. And we have also outcomes that are connected to branches by probabilities. And these are chance nodes. So for example, the probability of success with treatment A and failure with treatment A is derived from the RCT. And then the terminal health state and outcomes that are totaled. And then we do this for every single treatment options, and we calculate the difference between them to know the ICER. Believe me, this is very simple decision tree. And this is just to simple representation, visual representation of decision tree. Usually it's very complicated and it's done using softwares. So we have also Markov model, which is the most widely used tool. It's basically based on the movement between states over time, and it's caused by events. So the individuals enter the system or the model and progress from one health state to another based on transition probabilities. And this transition is at predetermined interval. So the movement of patients, as I said, from healthy to either sick or dead, depend on the data from clinical trials. So what are the knowledge requirements? We need epidemiological knowledge. We need medical knowledge to know the nature of the disease history, and the comparators. We need also economists knowledge. What are the data requirements? We need estimate for each possible outcome or health state, probabilities of occurrence, and cost of each resources used or consumed. This was my last slide. I see that I finished on time. Thank you.
Thank you so much, Dr. Hana. Even if you will take even more and more, I believe on behalf of the audience, we will hear very well, because it's very interesting, and I believe it's very important. So personally, I am convinced of the value and the importance of health economics.
Good news.
Yeah, and I would like to see if the audience also are convinced. So probably we can hear questions from the side. So for the attendees, you have two options to ask a question. Either you raise hand, which is on the down the lower bar. You can just click on raise hand, and we'll give you the mic to talk, or you can write in the chat. Until anyone with his hand or would like to ask, I can tell you, Dr. Hana, that I attended before a couple of times the training related to health economics, or previously years ago we used to call it pharmacoeconomics only. And this is the first time to understand well the differences between the four types. And you mentioned that what is present in most of the publication is the cost utility that is measured by the quality, while people are saying cost effectiveness. So for me, actually, I used to say cost effectiveness and quality. So thank you for this. I believe you highlighted also the point related to Markov way, which I believe really also very important. And when I saw the slides just before the presentation today, I was confused about this tree, and I found it's very difficult and complicated. And you mentioned this is the easiest one. Okay.
So we're doing this for non-economists. So I didn't want to bore you all, and didn't want you to. I didn't want people to be discouraged from attending the next session.
Yeah. Okay. No, I believe everyone is interested to attend the next session. That will be next week on the same timing. So we can go to the questions. We have one question from Dr. El Sadig. So I will give you the chance that you can talk now, please. You can just unmute and you can ask your question.
Assalamu alaikum. Thank you, Dr. Hana, for this nice lecture, which is focusing in uncovered topic, I think, through all the health sectors. Always we are attending lectures on scientific topics, discussing diseases or discussing cases or so many things, but rarely to find somebody who has this deep professional in health economics. I like it very much, and I think the topics which you are discussing. It is huge topics, and I think just you give us only just short notes, or in Arabic, just رؤوس أقلام, because this is the topic is governing all what everybody is doing every day in any sector in the healthcare systems. My question is regarding the health economics during pandemics, and especially now, as you know, we are under the COVID-19 pandemic. Is all these models, or any special models for such conditions?
Yeah, definitely. Not for the COVID affected patients in particular, but for example, the best idea that came to my mind is the vaccination, which is very cost effective without even doing a very complicated model, because once you vaccinate the patients, even if the vaccine is a bit expensive, then you are preventing the patients from being affected, which is extremely expensive to the healthcare system.
Yeah.
However, in my opinion, pandemics and crises are not the right time to apply the economic knowledge, in my opinion, because we don't have time to conduct the studies. We have to act immediately and try as much as we can to save lives. So by saving life, you're saving your economy. So as I said, I believe the right time to do this is before the pandemics. And we heard this in the news and we don't like it, but it's fact. This will not be the last pandemic, probably due to several options, including the increase in the number of the world population. We expect that we will have more pandemics in the future, and we need to be prepared. We need to be prepared by convincing the payers in conducting prevention measures, prophylactic measures, including vaccinations and other precautions such as lockdown, or even simply and very cheap is the self-hygiene. I hope I answered your question.
Yeah, thank you very much.
Thank you.
Thank you very much. Thank you, Dr. Al-Sadiq. And I believe your question was and the comment was really beneficial. That what we are hearing now, is more or less headlines, رؤوس أقلام, as you mentioned in Arabic. And I believe that, Dr. Hana, you have good experience in this, because I noticed that you have a couple of publications related also to COVID-19 pandemic and preparedness on this. So I believe this is quite important,
If you don't mind, Dr. Hijazi.
Yes.
Yeah, just as a request, a special request for Dr. Hana, if possible, just to send us or through you or through Cinfa company for the references for further reading.
Definitely.
Okay, that's great. Thank you, Dr. Hana. I believe this is not a request only from you, Dr. Sadiq, because here I see a written question from another Dr. Hana, who is one of the attendees. She is asking about the presentation.
Yeah, because the topic is the topic is very interesting one.
I'm glad you liked it, and I promise you that the next session will be easier to digest, because we're moving from the theoretical part to the very critical part where we use this evidence at hospital level at decision making when we want to choose between options. And I believe this is very relevant to physicians and pharmacists. So next session will be very interesting.
Okay, that's great.
Okay, thank you.
And in general, we for the whole course, we'll check with the speakers. Once everything is okay, of course, we will share the presentation through Cinfa to the attendees. Okay, probably some slides or some speakers might not share for a reason or another, but this is what that we will try to do for all the sessions, hopefully. Okay, so thank you. I see another question from Dr. George Jackson. So please, doctor, you make unmute and ask your question. Now you are not muted, but we can't hear you. So maybe you can make mute and unmute again, Dr. George. Okay, so probably you can write in the chat what you like to ask, because we can't hear you, and I will read your question. I see a question that can we implement this on the OTC products, implement the health economics models?
Well, most OTC products are as you know, very cheap. So I think it's not wise to spend the money on and time and effort on conducting huge cost effectiveness or cost utility studies only to study OTC products. However, if you look into the literature, you will find studies, for example, looking at the use of ibuprofen in patients with X and Y. And in my opinion, pharmacists at the retail pharmacists have very important role, because they are not like us informing decision making, they are making decisions, and they can shift, they can improve the efficiency of the system by, for example, suggesting cheap, good quality generics, or shifting for other non-pharmaceutical products, especially with patients who are geriatric or who have a lot of medications. If you are interested in this, I can talk a little bit about it in one of the future sessions, in the role of pharmacists in improving the efficiency of the system from economic perspective in all the sites of care, from clinical pharmacy, retail, in the IV, ICU, or high-risk areas such as, for example, oncology. Thank you.
Okay, so thank you. I hope that Dr. Ala answered your question, Dr. Abdulrahman. Thank you for the question and thank you for the answer. And still, we didn't have the chance to hear your question, Dr. George. So if you can write in the chat or in the Q&A, just in the lower.
Or if you share my email with the audience, and then if anyone have a question, he can send me an email.
That's very generous from you, Dr. Hannah. Thank you so much. Okay, any other questions? Maybe I can ask a question related to your answer. You mentioned that for OTC product, no need to conduct case or case study or whatever. So how long having such a case to make it, and from the effort and then probably from the cost point of view to conduct a case and study it?
Well, if we're talking about a complete cost effectiveness or cost utility analysis, or if we say HTA assessment, it may take for someone who is dedicated to do this, might take from 4 to 6 weeks at least. It takes also advanced softwares, supercomputers, help from epidemiologists and the clinician, probably advice from patients and physicians. So it takes a lot to conduct this kind of studies, because it requires deep knowledge about the mathematical skills and critical thinking, being creative about trying to predict all the future consequences of a disease. So I would say at least 6 months. However, if you want to do this at hospital level, just for example, BNT assessment, you would look into the literature, you will look into the decisions of other HTA agencies. At least you will do a mini budget impact model, which will take maybe around 1 week. And I will talk about this in details in my next session.
Okay, so I am asking a question for the next time. Okay, that's really good. And this makes it more interesting. And I am quite eager and interested to hear the next presentation from you. I see that we don't have more questions. We have nice comments about it's a good presentation or a good section or really some good appreciation from the audience. The session is interesting. So thank you so much for the attendees for these nice comments. And this is because we had an excellent speaker on a very interesting topic. So I really appreciated Dr. Hannah. Thank you for your time, for your effort in preparation, in presenting and delivering. And thank you for being patient with me during preparations for this. And I can tell you that once I communicated with Dr. Hannah about this, she was very excited and very interested to present and start in this program. So we really appreciate Dr. Hannah.
Thank you very much for the invitation and for organizing the whole program. Thank you very much.
Thank you so much. Thank you. Really appreciate. And
Dr. Ahmed, if you allow
yes.
me just to say one comment. Thank you very much, Dr. Hannah, on behalf of myself and on Cinfa. I would like really to express my great thanks to your effort. It was very interesting. And I would like also to thank all the participants. All comments is really great. And I would like just to highlight that we will continue with Dr. Hannah next week. So maybe next week you will hear more comments and you will see more questions. It will be very interesting. Now you open eyes about a lot of things and the questions. So I think next week at the same time, I hope everyone in the attendees be sure that they received the link and they received and booked in the calendar. So not to miss the next session. It will be, I think, on 22, which is next Wednesday.
Yes.
At the same time. Again, Dr. Hannah, thank you very much.
Most welcome and thank you.
And from my side, another thank you to you, Dr. Mustafa, and to Cinfa for hosting and preparing and sponsoring such an interesting program. So thank you, Cinfa, thank you, Dr. Mustafa, thank you again, Dr. Hannah, and thank you to all attendees, and goodbye.